Welcome everyone to this webinar on tips and tricks to examining the mid-sagittal view at 11 to 14 weeks, presented by Dr. Reem Abu-Rustam. The AIUM is accredited by the ACCME. This webinar is designated for 1 AMA PRA Category 1 credit. By the conclusion of this webinar, participants should be able to understand how to obtain the optimal mid-sagittal view and recognize anatomic landmarks and markers. Viewers should also understand the potential utility of obtaining a volume from the mid-sagittal view. As an ACCME accredited provider, it is the AIUM's policy to ensure that the contents and quality of this activity are balanced, independent, objective, and scientifically rigorous. All individuals who are in a position to control the content of an educational activity are required to complete a disclosure form. All disclosures are reviewed by the AIUM, and any conflicts of interest are resolved or managed prior to an activity. The presenter and AIUM staff members involved with this activity have no disclosures. At the conclusion of the webinar, you will be able to access the CME test and evaluation located on the AIUM website. Participants who complete the post-test with a grade of 70% or higher will be awarded 1 CME credit. Credits for this webinar are approved for physicians, sonographers, and radiologic technologists. During today's presentation, if you have questions for the presenter, you may type them into the question box on the right side of your screen. You will be able to submit questions throughout this webinar, but the presenter will not begin answering until the end of the presentation, at which time she will answer as many questions as possible. A recording of this webinar will be available on the AIUM website. And now we're pleased to present Dr. Reem Abu-Rustam.
Okay, good afternoon everyone. It's an honor for me to be with you here today, and I would like to thank the AIUM for the invitation to give this webinar. I have no disclosures. Our objectives, we've already covered them. We're going to understand how to obtain the mid-sagittal view, the anatomic landmarks, talk about the various markers, their implications and clinical applicability, and finally the potential utility of obtaining a volume from the mid-sagittal view. We'll start with the optimal mid-sagittal view. This is the same view where we look at the nuchal translucency, and we can see the nasal bone, the fetal palate, the mandible, the thalamus, we can see the sphenoid bone along the black line, the midbrain, the brain stem, medulla oblongata, and the fourth ventricle, which is also referred to as the intracranial translucency, and we can see the choroid plexus within it designated by the asterisk. The cisterna magna is also there, and the dotted line is along the occipital bone. And we should employ magnification and have the fetal head and thorax occupy at least 2/3 of the image. As we are scanning the fetus and we are trying to obtain this view, we try to see these landmarks, the thalamus, as I mentioned, and the midbrain. We need to make sure that the fetal neck is neither flexed nor extended, but it is in a neutral position. Your ultrasound beam is perpendicular to the fetus, and in the cine, no magnification is maximized, but again, when you freeze the image, this would be very important. It's important to see the nasal bone, the mandible, and to look for the palate and delineate the amnion from the nuchal translucency. And this is very important when you're measuring the nuchal so that you don't erroneously get a large nuchal translucency. We can also see all the landmarks we talked about with respect to the intracranial translucency and the nuchal translucency as well. Now, the mid-sagittal view also has a vascular view. This is where we would be able to see the ductus venosus, and most recently there has been a role for looking at the superior mesenteric artery. And here, this is the mid-sagittal view with high definition flow. You can see the umbilical artery, and right parallel to it, the second vessel is the superior mesenteric artery, and we'll talk about its relevance in a minute, and the third is the ductus venosus. Now, there are various hidden markers within the mid-sagittal view, and this is where we will be heading more and more in the future as we start utilizing the 11 to 14 week scan for fetal anatomy. But it's very important that we revisit the key elements that got us here. So we're going to talk a little bit about the nuchal translucency, the nasal bone, the facial angle, and the ductus venosus. It all started historically with Langdon Down in 1866 when he described that the skin in fetuses with trisomy 21 is deficient in elasticity. And it was Professor Benacerraf in 1985 who first described the nuchal fold, where it was reported that there's a sonographic sign consisting of increased skin or soft tissue thickening at the back of the fetal neck during the second trimester, which correlates with the diagnosis of Down syndrome. 7 years after Professor Benacerraf described the nuchal fold, we had the nuchal translucency from Professor Nicolaides, where they reported that a nuchal translucency in the first trimester of greater than 3 millimeters highly correlates with chromosomal aberrations. So this was exactly 25 years ago, and so much has changed in the past 25 years. But the key requirements for the nuchal translucency are what constitutes the optimal mid-sagittal view. We usually have the fetus between 11 and 14 weeks with a CRL between 45 and 84 millimeters. You have to have a sagittal section employing magnification, and your caliper should measure to the 10th of a millimeter. As we discussed earlier, you should identify the amnion, measure the maximal thickness, and have a fetus in a neutral position. And particularly for the NT, we have to be mindful of the presence of a nuchal cord, which is present in 5 to 10% of cases. At least 20 minutes may be needed for the NT. And with the nasal bone, it is practically the same requirements, but the most important thing is that your ultrasound beam should be vertical to the nose, and the first line that you see is the fetal skin. The second line is the bone and cartilage, and then you can also see the tip of the fetal nose. In cases where there's an absent nasal bone, it's so important that you have that proper mid-sagittal view. The facial angle is not really used routinely much anymore, especially in the era of cell-free DNA, but it is in the same mid-sagittal view where you would place a line along the palate and another line along the frontal bone, and this angle in normal fetuses is about 85 degrees. When you have chromosomal aberrations, there's flattening of the face, and this angle is usually larger. With respect to the vascular view of the mid-sagittal view, this is where we look at the ductus venosus, a marker for cardiac abnormalities, as well as chromosomal aberrations. Now, the nuchal translucency, which started 25 years ago, has given us today access to more than 70% of fetuses whose mothers are presenting for the nuchal translucency. Of course, these numbers now, with the availability of cell-free DNA, are declining. Prior to cell-free DNA, the rates in the US were in the neighborhood of 85%. And I hope to convince you at the end of this talk that we should not lose this window at 11 to 14 weeks. And even though we are not measuring the NTs, obtaining that mid-sagittal view for screening is so important. Because this is all of congenital malformations that affect 3 to 5% of pregnancies, and they are the most common cause of infant mortality. We still have suboptimal detection rates all over the world, where rates are reported to be anywhere between 16 and 77%. In Europe, a recent study has shown that the incidence of major congenital anomalies is roughly 23.9 per 1,000 live births. Compare this to chromosomal aberrations, and they are 3.6 per 1,000 live births. So if we were to really compare things and put them in the balance, congenital malformations are 7 times more common than chromosomal aberrations. And looking at the fetus in the first trimester beyond the embryonic phase at this fetal phase is so critical, because today with the technological advances, we are able to see so much. We are able to do a full anatomic survey from determining fetal situs to looking at genitalia, assessing the intactness of the abdominal wall, looking at fetal kidneys, the bladder with a 3-vessel cord. In addition, we can assess the fetal heart. And there are critical structural abnormalities that we should not be able to miss. But how good are we? Is it really, do we really have good detection rates? And I will be referring to 2 main studies throughout the remainder of this talk. The first is a study on 45,000 pregnancies from Nicolaides' group back in 2011, where they reported that the rate of detection of structural abnormalities at 11 to 13 weeks was 43.6%. Now, this varies by the organs under evaluation. For instance, in their series, all cases of acrania, alobar holoprosencephaly, exomphalus, gastroschisis, megacystis, and body stalk abnormalities were detected. However, they were only able to detect 5% of facial clefts, 14% of open spina bifida. Now, a recent systematic review by Rossi reviewed several studies, including the study by Nicolaides, and they reported that the overall detection rate of an early sonogram is 51%. Of course, this is affected by the area under evaluation. For instance, for abdominal wall defects, the detection rates are as high as 88%. For the brain and spine, 51%. And for the fetal face in that study was 34%. A recent study that is still in an accepted form ahead of print in the White Journal from the Netherlands looked prospectively at 5,534 women who were coming in for the combined test, at which time a sonogram was done to look for structural abnormalities. And they were able to detect 45.3% of all structural abnormalities, which is similar to what was reported in the Nicolaides' group. Again, all severe cases were detected at that point in time. So with respect to Rossi's group, they divided the anomalies based on the percentage based on the area under question. For instance, acrania could be detected 100% of the time versus agenesis of the corpus callosum, which was detected 0% of the time. And intuitively, as gestational age increases, our ability to detect abnormalities increases. And so now to the role of the midsagittal view. We're going to look at the role of the midsagittal view as a standalone and as a view that has a particular marker within it to assess for CNS abnormalities, abdominal wall defects and congenital diaphragmatic hernia, GU abnormalities, open spina bifida, facial clefts, gastrointestinal abnormalities, and others. So we'll start with the CNS. And I will be referring to the 2 studies that I had talked about. So we will start with the detection rate of CNS abnormalities from the Nicolaides' group. You will see that for acrania, the NT was abnormal in roughly a quarter of the cases. However, sonographically, they were able to detect 100% of the cases. This was back in 2011. And from Rossi's study, acrania falls in the 100% detection rate group. And so as you're just trying to get your CRL and get that midsagittal view, you should be able to suspect acrania from the absence of the cranium and the irregularity as we see here. We definitely do not need 3D ultrasound to diagnose acrania. With respect to abdominal wall defects, now abdominal wall defects would be much easier to detect in comparison to congenital diaphragmatic hernias. So from a midsagittal view, you would be able to see an abdominal wall defect, not necessarily congenital diaphragmatic hernia. And this is according to the Nicolaides' group. The NT greater than the 95th centile was abnormal in only 18%, up to 18% of those cases, but sonographically 100%. This is not congenital diaphragmatic hernia, this is abdominal wall defects. And these fall in the 50 to 99% detection rate. So we come to the superior mesenteric artery that I introduced earlier. Remember that in this view, as we are looking at the vascular view of the midsagittal view, we are able to see the umbilical artery as the first vessel. And the second vessel is the superior mesenteric artery, and it should be parallel to the umbilical artery. And the third is the ductus venosus. Well, in case of an abnormality, we will have a variation there, and I'll show it in a second. This is a case of exomphalus, and you definitely do not need the superior mesenteric artery to diagnose these cases. We looked at a case of this is a case of a congenital diaphragmatic hernia at 12 weeks, 5 days. And again, these can be very challenging to diagnose in the first trimester. And this is where the role of the superior mesenteric artery may come in. In normal cases, remember that the superior mesenteric artery has a direction of flow that is downwards. It is parallel to the umbilical artery. However, in the recent study in the Journal of Ultrasound in Medicine, they were able to show that in cases of exomphalus or a congenital diaphragmatic hernia, the direction of the superior mesenteric artery changes. And so now it is upwards, away from no longer parallel to the umbilical artery. So this would be helpful for pointing towards a congenital diaphragmatic hernia. I personally believe this is its primary role, not with an abdominal wall defect. With respect to the GU tract, from Nicolaides' study, sonographically you are able to detect up to 100% of cases. A nuchal is may be abnormal when the bladder length is more than 16 millimeters in 50% of cases. And this belongs in the 50 to 99% detection rate group. Megacystis should be clear when you are trying to measure your CRL and assessing the fetus at this point in time, and you can use color Doppler to confirm that this indeed is the bladder on an axial view. You do not need a 3D ultrasound to show this, but you can clearly see the megacystis in this case. Now we move on to open spina bifida, which is a challenge, and in the study from Nicolaides, nuchal translucency was abnormal in only 4.7% of cases, and sonographically they were only able to detect 14.3% of cases at that point in gestation. And this is why it's so important to have a marker that will help us in identifying these at-risk fetuses. In Rossi's review, this belonged in the 1 to 49% detection rate group. It is not always feasible to get good views of the fetal spine, and this is why we have the intracranial translucency, which was introduced by Shawi in 2009 as a marker for open neural tube defects. And what is the intracranial translucency? It is the fourth ventricle that we talked about earlier, where you have the choroid plexus within it. This is an area that should be clearly visible when you obtain your midsagittal view, and it is measurable. There is a normogram already established for this. The idea is that when you have open spina bifida, as we do in the second trimester, the fourth ventricle will collapse and this area will not be clearly visible. However, there are concerns with just using the intracranial translucency, as I will show in a second. But when you obtain your midsagittal view, you can eyeball the posterior fossa and try to look for the intracranial translucency. And this is a schematic from Shawi's paper that points to where the intracranial translucency should be. Again, when you have the proper midsagittal view, you should clearly see the thalamus, the midbrain, the brainstem, and the medulla oblongata. And the intracranial translucency is right there. This is a 12-week, 1-day fetus, and if you look at the posterior fossa here and compare it to the normal, you will see that this does indeed look abnormal. However, there are limitations to the intracranial translucency, and in 2011, Lachman and colleagues looked at another area in the posterior fossa, which is the brainstem and the brainstem to occipital bone. And I'll show it in a schematic here. You have the mid-sagittal view again of the fetus. Remember the brainstem, and it is between these two lines. And right below the brainstem, this is your fourth ventricle, and this is the choroid plexus of the fourth ventricle, and this is the occipital bone here. And so what Lackman and colleagues did is they looked at the width of the brainstem and its ratio to the brainstem to occipital bone. And what they were able to see is that in cases of open spina bifida, your fourth ventricle, the intracranial translucency, is going to collapse. And so the brainstem is going to be wider. It's going to be greater than the 95th centile. And this is why the ratio of your brainstem to the occipital bone is going to also increase. These are markers. Now, this is an example of a 12-week, one-day fetus who came in, and you can see that something just does not look right in the posterior fossa. Looking at this fetus, you will be able to see that there was a suspicion of a neural tube defect. The mother would not give permission to do a transvaginal scan, and she was brought in 2 weeks later at 14 weeks, 2 days, at which point there was a clear lemon sign and a clear banana sign of the cerebellum. As you can see, the cerebellum here, and this baby did have open spina bifida. And so looking at the posterior fossa, eyeballing it will really help you to try and pick up these babies at an earlier point in gestation, being very mindful to the limitations. And this is another case. Again, you do not need 3D to confirm this, but you can see it clearly. You can see the defect. So how well does it perform? There was a recent systematic review and meta-analysis from looking at the intracranial translucency, and we have to be very careful with the introduction of any new markers. They looked at various prospective studies, and what they showed is that the intracranial translucency by itself had low diagnostic accuracy in prediction of open spina bifida, where its sensitivity was only 53.5%. It is highly specific at 99.7%. So it is very important not to raise concern and alarm to families early on. The recommendation would be, when you obtain this mid-sagittal view, to take a look at the posterior fossa, to look at this area. If you are suspicious, do a transvaginal scan, or bring the patient back in a couple of weeks to confirm the diagnosis. Next, we're going to talk about facial clefts, which are again another challenging area for early detection in the fetus. And looking at the Nicolaides' study, their detection rate sonographically was in the neighborhood of only 5%. And this, again, from the Rossi group, was in the group of detection between 1 and 49% overall. So looking at the fetal face, we are able to assess the fetal face at 11 to 14 weeks. We can see the orbits, we can see the maxilla, we can see the mandible, we can see the upper lip, and to families who have had a prior affected child, if there's the ability to generate a 3D image, this is a powerful tool of early reassurance. However, we are far from perfect, and this is why we need indirect markers to look for facial clefts early on. And from Shawi again comes another marker, which is the maxillary gap. This is something that can be looked at from the mid-sagittal view again, where you concentrate on the view of the fetal palate. You want to ascertain that there is proper ossification and that there are no gaps. And if there were to be a gap within the palate, it should measure it should have a certain upper limit beyond which there is concern for a facial cleft. And we look at the schematic that they have in their paper. So you can see this is the mid-sagittal view. You have the maxilla, you have the nasal bone and the mandible, and the intracranial translucency. the occipital bone, and the nuchal again. And so this should be very well ossified. However, if there were to be a gap, you should measure the gap, and the upper limit of normal is 1.6 millimeters. And so if you were to have a gap and the gap is 1 millimeter, this should be reassuring. And here is an example of 4 fetuses with normal maxillas that contain no gaps. From Shawi's study, they had 86 normal controls, and then they had 37 fetuses with an isolated facial cleft and 49 fetuses with facial clefts, among other defects. And what they were able to show is that in 93% of normal fetuses, there is no gap present. And in the remainder, if there were to be a gap, it measured less than 1.5 millimeters. I'm sorry, I said 1.6 earlier. So it should measure less than 1.5 millimeters. Now, if we look at fetuses with a facial cleft, roughly 2/3 of them have a partial gap. And if they have other defects, that percentage is higher. And so the take-home message here is you look at the mid-sagittal view, you assess the palate. If it is well ossified and you do not have a gap, then this is reassuring. If there were to be a gap, measure it. If it is greater than 1.5 millimeters, that fetus would require further attention. And I'm going to put up 20 images of fetuses. They are not all perfect mid-sagittal views, for you to try and look at them and try to identify those whom you feel are going to have a facial cleft based on the maxillary gap. And I'm going to identify them here for you. The first one is fetus 5. You can see that the palate is not well ossified and there is a large gap there. The second one is fetus 8, and again, this gap measures greater than 1.5 millimeters. And then we have fetus 12, where this really is not well ossified. And this baby had multiple other malformations. And finally, fetus 17, where you can see that there is a very, very large break there and only a partial portion of the palate that is visible. Next, we will move to the GI tract, where there are various limitations. As we know, many of the gastrointestinal abnormalities are detected even late in the second and early third trimester. From Nicolaides' study, the rate of detection of anal atresia was not reported. They did not have any cases, but again, from previous studies, they did report that 0 out of 1 case was detected. This is something very difficult to detect. And in Rossi's group, this is in the 0% detection rate. However, in 2010, a group in France with Professor Bolt looked at what they called the evanescent pelvic lucency. And how they described this is when you have a mid-sagittal view of the fetus, you will see a large pelvic cystic structure that tends to disappear in the second trimester. And they found that this is associated with anal atresia. And so if you see a large pelvic lucency that disappears in the second trimester, this may herald anal atresia. And finally, I put under other triploidy, because just by trying to obtain a mid-sagittal view, even in this fetus with a very flexed neck, and this fetus remained in this position, you can see a clear discrepancy between the volume of the fetal head and the rest of the fetal body. And you can see here the head and the thorax. The nuchal translucency was normal in this fetus, and of course cell-free DNA is normal in these cases. The baby had abnormal limbs. So just from eyeballing the mid-sagittal view and from seeing a discrepancy in the volume of the fetal head with respect to the rest of the body, this is a sign for triploidy. Now we have covered all of the hidden markers of the mid-sagittal view, and I'm going to move on to volumetric potential. And I would like to start with the idea of the automated multiplanar imaging, which was introduced by Professor Abu Hamad back in 2005. And the idea is when we obtain a 3D volume of any area of the body, then technically within that volume it contains all the 2D anatomical planes that are required for a complete evaluation of the structure. So if we obtain a volume of the fetal heart, then within this volume we have all the 2D planes to do a complete assessment of the fetal heart, from the 4-chamber view to the 3-vessel view, outflow tract, and so on. And for every organ, the 2D anatomical planes are organized in a constant anatomic relationship to each other. This relationship can be defined, and you can then devise a software where you obtain a volume of an organ, and with the press of a button, the program will automatically generate these 2D planes for you for a complete evaluation of the organ. And this has been done with the fetal heart. Well, what's so unique to the first trimester is we are able in one volume to obtain an entire volume of the fetus. And technically within this volume, we would have all the anatomic and biometric planes that would be required for an offline assessment of the fetus later on. So when you are scanning and you have your optimal mid-sagittal view and you do 3D ultrasound, you can just obtain a sweep and save it for later on, because you can go back and do a full anatomic assessment by manipulation of that volume. And we tried to look at this several years ago in 2012, where we tried to investigate the spatial relationship between 8 anatomic and biometric planes in the 11 to 14-week fetus. And so this was a retrospective study on 63 fetuses on whom we had stored 3D, 4D volume data sets, all obtained from the mid-sagittal plane. And so you would have this mid-sagittal plane of the fetus optimized, and from here you would obtain a sweep. And once you obtain a sweep, you will be able to display it in the 3 orthogonal planes, where you have the mid-sagittal view of the fetus in plane A and an axial view of the fetus in plane B. Now, in order for us to measure the anatomic distance between the various planes, we decided to use the plane of the abdominal circumference as our reference plane, or plane 0. So once we obtained the mid-sagittal view, we optimized it, and then we moved the marker dot to the level of the diaphragm, because if this is placed in plane A, where the diaphragm is, in plane B, we should be able to obtain the fetal stomach. So this was our plane 0. And from here, we would scroll through the volume. We would choose plane B as our reference plane, and you would scroll through the volume, cephalad and caudad, to get all the other key planes. And so this is plane 0, where we have the stomach. And then if we are going to move towards the fetal head cephalad, plane 1 is where we see the fetal heart. Plane 2 is where we see facial bones. Moving upwards, plane 3, we see the orbits. Further on up, plane 4, we see the plane of the biparietal diameter, and plane 5, we can see the butterfly sign, which is the plane that helps us rule out holoprosencephaly in the first trimester. Now we move back down to the plane 0, the stomach, and now we're going to move caudad. And we get to the cord insertion. This was plane -1 below the stomach, and plane -2, which is where the fetal bladder is. And again, this is a schematic to show the volume of the fetus. You get plane 0, the stomach, and from there you get the 7 other anatomic and biometric planes. And we were able to determine the distance for moving from plane 0 to all of these planes. So roughly there is a mean of 8.27 millimeters between the plane of the circumference and the plane of the fetal heart. And to go down to the bladder, it's about 18.72 millimeters. This is a box plot representation of all of these planes, and ultimately you can obtain a volume of the fetus and with the press of a button get the various anatomic and biometric planes. And the practical take-home message from this exercise is when you have 3D capabilities and you do have a good mid-sagittal volume of the fetus, obtain mid-sagittal view, obtain a volume, store it, and you are really able to navigate through it and reassess various structures. You have to keep in mind safety. Anytime we're working in the first trimester, it is very important to be mindful to safety concerns, particularly when we're employing Doppler. There are safety statements issued by both the AIUM and ISWAG, and we have to adhere to the ELARA principle. Because a recent study from NTQR led by Dr. Bromley showed that clinicians seeking credentialing of NT are not demonstrating compliance with the recommended use of the thermal indices while you monitor the acoustic output on the images. And just as a refresher, we should all be very careful. We should know where the thermal index is designated on our images, and it should be less than 1. And this is critical in the first trimester. Finally, there are several technical and personal limitations as we look at the fetus in the first trimester, even if it is only the mid-sagittal view, because this does require training. You have to have a machine with good resolution. Maternal body habitus plays a role. However, there are emerging studies that show us that we may be able to do better anatomic assessment of the fetus at this point in gestation when the maternal body mass index is more than 40. And there's a recent publication from Dr. Letty Romero, I believe, in JAM that was recently published to that end. The developmental stage of the fetus is very important to keep in mind because there are limitations early on. This is time consuming. Remember, I showed that the average time for a nuchal is 20 minutes, and when you are looking at various other markers, you will need added time. And we have to be very careful not to cause undue parental anxiety. But for those who are not doing anatomical assessments at this point in time, my recommendation would be when you have a patient with a low BMI and we have a fetus in an optimal position, try to obtain cines, try to obtain volumes, and then you can look at them when you may have the time, and eventually this becomes part of your scan at 11 to 14 weeks. The greatest challenge is always the low-risk patient. In conclusion, I hope that I've been able to show you that the mid-sagittal view is a critical view to obtain even in the era of cell-free DNA when we're not looking at the nuchal translucency, because just by eyeballing it, you are able to screen not only for chromosomal aberrations, you can screen for triploidy, you can screen for facial clefts, you can screen for open neural tube defects, you can screen for abdominal wall defects, you can screen for congenital diaphragmatic hernia, you can screen for GU abnormalities, all from one single view of the fetus. It provides information way beyond the NT, the nasal bone, the facial angle, and the ductus venosus. We should understand all the various markers, their implications, but also be mindful of limitations. One of our biggest roles is to provide early reassurance and not cause undue parental anxiety. So we have to be very careful with the introduction of any new markers, especially when our experience is limited. We should always exercise caution and adhere to the ELARA and safety recommendations. But the mid-sagittal view is a very powerful tool for early reassurance in the first trimester, and it's time to look beyond the NT. And I thank you for your attention. Okay, now I'm going to be looking at the questions and trying to address them. The first question is, what is the detection rate with an absent superior mesenteric artery in congenital diaphragmatic hernia and exomphalus? This is a great question, not only for the superior mesenteric artery, but for various markers. Our main problem is most of these markers, we do not have large prospective studies that have validated the detection rates. And so we have to be very careful when we use them. The paper that discussed the superior mesenteric artery, the superior mesenteric artery is present, it is not absent, but its direction, instead of being parallel to the umbilical artery, its direction is pointing cephalad, and so that will alert us. So there is really no detection rate yet. Should it be included in routine screening? Again, how much of these markers you include in your routine screening really depends on time and experience. Personally, I have not started incorporating it routinely in my practice. I look for congenital diaphragmatic hernia by assessing the cardiac views and the views of the upper abdomen. I would like to use it and validate this in a case prospectively. Another question is, does a collapsed cisterna magna with a present intracranial translucency represent the occipital bone? So let me clarify again with respect to the brainstem to the occipital bone ratio. When you have the mid-sagittal view, the brainstem is above the cisterna magna. And what happens is, when you have an open spina bifida, the cisterna magna is going to collapse. And so your brainstem may shift and it will look larger than it is. And so the ratio, first of all, your brainstem, if you were to measure it in an anterior-posterior diameter, it's going to be greater than the 95th centile, that is expected. And then the ratio of that distance to the distance of to the occipital bone is going to change as well, and it's going to be larger. What is your reference for transvaginal ultrasound when BMI is over 40? Okay. The question, the point here that I mentioned with the BMI greater than 40, the study was done transabdominally. And when you compare the ability to assess the fetus at 11 to 14 weeks in a mother whose body mass index is greater than 40, you are able to do a more complete scan than at 20 weeks. The reason being is, most of the time around 12 weeks, the baby is lying in a sagittal position in an area under the pannus. So you may have a better acoustic window than when she comes in at 12 weeks and the baby is higher up and you have more adipose. Definitely transvaginal ultrasound has a very big role. However, that's not universally accepted in the same rates all over the world, and that does require some level of expertise to know how to manipulate the probe and obtain these views. If this is a possibility, definitely it is superior for many structures, especially with the high resolution vaginal probes that are available today. Another question is, what would be the best CRL measurement to do anomaly scan when the CRL is between 45 to 84 millimeters? This is a very good question, because as the baby gets bigger, your ability to see the structures becomes much clearer. A lot of time we don't have control over when the patient comes in, and there may be an issue with the patient's dating. However, ideally, when we are able to control for this, I try to schedule the 11 to 14 week scan at roughly 12 weeks, 5 days. Beyond the 70, 75 millimeters, the ability to visualize the heart is much better. And for safety concerns too, utilization of color Doppler, high definition flow, even though you're adhering to the recommendations, beyond 12 weeks is definitely better than before 12 weeks. Would superior mesenteric artery course be deviated? Yes. The superior mesenteric artery course would be deviated in case of a congenital diaphragmatic hernia or an exomphalus. So instead of it being parallel to the course of the umbilical artery pointing downwards, it would be pointing upwards towards the fetal head. And it would be interesting to see prospective data on this. In the cases of early congenital diaphragmatic hernia that I have, unfortunately, I did not have any vascular volume stored, because this would have been very interesting to see. There was a question for a reference on the transvaginal ultrasound. Please, if you can send an email and I will respond to you via email. You can send the email to the AIUM and they will forward it to me, and I will give you the exact reference. But definitely it is in the Journal of Ultrasound in Medicine in 2017. It's one of the more recent issues. What is the PRF one should use for SMA visualization? I would use the same settings that you are using for your ductus venosus, because technically if you have the fetus in the proper lie, if you have the proper mid-sagittal view, then you will be able to see umbilical, superior mesenteric artery, and ductus venosus all simultaneously. And I think that was the end of the questions. We've gotten to them all. I thank you for being here and for giving me the opportunity to be with you, and I turn the control back to the AIUM, Kathy and Darcy. Thank you very much.
Yes, thank you so much, Dr. Abu Rustam, for that excellent presentation, and our thanks to all of you who participated today. Everyone, please remember to complete the post-test and the activity evaluation. We hope you enjoyed this presentation and will join us again for future webinars. So long, everyone.